Welcome everybody to Pharmacy Grand Rams for the month of March. We have with us today Liam Walsh. For those that don't know him, Liam is our amazing emergency department pharmacist here at the Queenstown Regional. So Liam is going to talk to us today about the CRASH-3 trial for Journal Club. So I'll hand it over to you, Liam.
Thank you. I've got an extra paper copy here too, if anyone wants it. So like Heather said, I'm going to be talking about the CRASH-3 trial, so the effects of tranexamic acid on acute traumatic brain injury. The reason why I decided that this was the trial that I'd look at is because St. John Regional was the only North American site actually involved in this trial. We recruited 7 out of the 13 or so thousand patients. So I didn't make any money from this. I was involved briefly just setting up storage logs and destruction logs of some of these drug treatment packs, but I didn't receive any financial compensation for doing that. $10,000 was given to the research team in the emergency department here at the regional from the New Brunswick Trauma Program, which is a New Brunswick government-sponsored organization. So we're going to describe the rationale for the use of tranexamic acid in head trauma, discuss the evidence prior to CRASH-3 briefly supporting tranexamic acid in the use in trauma in general, and we're going to talk about the evidence surrounding the use of TXA in head trauma specifically and how this may or may not apply to our local population. So this is just a little case to think about as we go through the evidence. So we've got a 44-year-old female who presents to the emergency department after falling approximately 18 feet from a ladder, striking her head on the driveway in the process. So upon arrival to the emergency department, she's got a decreased level of consciousness with a Glasgow coma scale of 9. I'll delve a little bit deeper into what that means in a moment. Blood pressure is elevated, 197 on 105. During her primary trauma survey, she's got a 4-centimeter scalp laceration and a possible depressed skull fracture. The primary survey is cut short when the patient has a generalized seizure lasting about 2 minutes. She's intubated for her airway protection and sent for urgent CT scan of the head. So keep this unfortunate lady in mind as we go through this. So head trauma, this is just a very high-level overview of why we're concerned about head trauma in general. So our biggest concern in head trauma for serious complications is intracranial bleeding. Unlike other types of traumatic bleeding, the blood inside your skull has nowhere to go. So it just expands and pushes on your brain, leading to shifts in the structures inside your skull, causing hypoxic brain injury and death or disability. And the disability from these severe traumatic events is often irreversible or sometimes only partly reversible. So a lot of the damage is done quite quickly and is hard to do anything about. So here are a couple of pictures just to illustrate a little bit of an intracranial hemorrhage. So these are CT scans of the head with 2 different types of intracranial hemorrhage. So the one on the left is an epidural hematoma. So you can see that it's kind of expanding and pushing out on the structures. If you look at this particular, can the other side see my mouse that I'm pointing? Okay. So if you look at this line here, this is called your midline. It's supposed to be straight down the middle of the skull here, and it's pushed over to the right, which is evidence of the brain actually shifting and being pushed by that hematoma. The one on the right-hand side is a subdural hematoma, and you can this one's illustrated a little bit better because it's got the line of where it's supposed to be, and you can see that the midline is actually pushed to the left of this. So it's essentially the blood is pressing the brain against the other side of the head. So the GCS, or the Glasgow Coma Scale, I'll be using these numbers a little bit to talk about this evidence. It's a scale from 3 to 15. that's a quick method of assessing how severe someone's neurologic injury might be. So it's based on verbal response, eye opening, and motor response. Each category is assigned a certain number of points for a total score of up to 15, a minimum score of 3. Anything under an 8 represents a severe neurologic deficit. Anything above represents a kind of 9 to 12 would be a moderate neurologic deficit, and above 13 would be considered a mild neurologic deficit. So those numbers will be important when we review some of the data later. So what is tranexamic acid? Most of you are probably familiar, but products of fibrinolysis are increased in intracranial hemorrhage patients, and the presence of these products can actually predict expansion of the intracranial hemorrhage. So because tranexamic acid is a inhibitor of plasminogen, it inhibits fibrinolysis or stops clot breakdown, and this is the mechanism by which it slows or stops bleeding. So this is kind of where the development of the hypothesis, maybe this drug is going to be helpful in severe bleeding, has come from. It's also been used for quite a while in other bleeding-related pathologies, so menorrhagia, severe nosebleeds, topical tranexamic acid is used in the emergency setting, and sometimes hemoptysis, inhaled tranexamic acid is used. So there's a couple of evidence-backed other uses for this drug, and kind of leads towards our guesses as to that it might be useful for traumatic injuries as well. So why did they bother doing this study? This is based on results of a CRASH-2 trial. So CRASH-2 studied patients with massive hemorrhage due to trauma, but excluded patients with intracranial bleeding. So intra-abdominal bleeding, pelvic bleeding, those type of things, these were all included in CRASH-2. And CRASH-2 trial showed that tranexamic acid did reduce mortality in these massive hemorrhage patients. Over 60 million cases of traumatic brain injury occur a year worldwide. It's a little harder to find Canadian statistics, but multiply our percentage of the population by that, and you can presume that it's roughly the same. Traumatic brain injury is associated with significant mortality and morbidity, and significant cost as well that goes along with those two. So the authors, because of the results of CRASH-2, hypothesized that tranexamic acid might benefit isolated intracranial hemorrhage as well as extracranial hemorrhage. So before doing this study, the authors did a literature search and revealed 2 small randomized trials reviewing tranexamic acid and traumatic brain injury. Total of 510 patients. Analysis of both of these trials did show a reduction in mortality, but the trials were considered, or the total number of patients were considered too small to accurately predict or accurately apply those results. So they designed a large-scale study to hopefully reach the same conclusion or assess whether that conclusion could be reached. So what happened? They did nearly a 7-year double-blinded randomized controlled trial designed to answer the question, does tranexamic acid reduce morbidity and mortality in traumatic brain injury patients? So the trial wasn't cut short, but they didn't quite reach their goal. Their goal was 13,000 patients randomized. They got pretty close, 12,737 in 175 different hospitals across 29 different countries, of which the St. John Regional was one of those hospitals. So this is a quick summary of what they're looking for. They want to know whether tranexamic acid, 1 gram over 10 minutes, followed by an additional gram over 8 hours, compared with placebo, reduces head injury-related death in hospital within 28 days. So why are we concerned about this? Previous evidence does suggest that the early administration of tranexamic acid does reduce mortality in trauma patients. We can't say the same thing for trauma patients with isolated intracranial hemorrhage, or at least we couldn't before this study was done. And based on previous evidence, TXA administration has been incorporated into a lot of emergency department and pre-hospital medicine protocols with the intent of reducing mortality in these trauma patients. So in New Brunswick, Ambulance New Brunswick's protocol does include tranexamic acid administration in the field for trauma patients with massive hemorrhage, as well as our ED and hospital-wide massive transfusion protocols include this treatment for trauma patients. So if proven effective, including head trauma patients in these protocols could potentially save their lives. So, like I said, they included 12,737 patients with traumatic brain injury. They were eligible to be enrolled if the following criteria were met. So they needed to be adults, 16 years of age or older. They needed to present to treatment within 3 hours of their injury. Their Glasgow Coma Scale had to be 12 or lower, or they needed CT evidence of bleeding in their head. They could also not have major extracranial bleeding. So essentially, patients with isolated head trauma with at least a moderate neurologic injury or deficit before CT, or any evidence of bleeding on a CT scan, regardless of the level of deficit. I don't know how well anyone can see this, probably very poorly. So the only thing I wanted to highlight on this table 1, the baseline characteristics, is the mean age, 42-ish. So this study included, on average, younger patients than the average population of New Brunswick, but traumatic brain injury is sometimes a younger person's problem. Anecdotally, I see a lot of elderly patients with traumatic brain injury, probably more so than young people. But so this is just something to consider. Maybe the average age of these patients is younger than the average age of patients that we see in New Brunswick. So compared, say, 1 gram infused over 10 minutes, followed by a second gram infused over 8 hours, to placebo. So the way they randomized these patients is they sent out treatment packs consisting of vials of either tranexamic acid or sodium chloride, which acted as the placebo. They were identical to one another in appearance, except for a unique pack number. Pack number was linked to what the actual treatment pack contained in a secure, blinded database. So investigators and patients were all blinded to the contents of what the treatment pack actually was. So the placebo group or the treatment group received something infused over 10 minutes, as well as something else infused over the 8 hours. Here's the trial profile. Here's how they did everything. So of the 12,737, approximately half of each, 1-to-1 were randomized into either placebo or the treatment group. A few patients. So they initially, this kind of highlights, in the trial they initially were looking at treatment given within 8 hours of injury. They reassessed this based on, they cite extra or outside the trial evidence pointing towards the 3-hour window. CRASH-2 trial used this 3-hour window to prove their mortality benefit. So after the patients were about 4 years into the trial, they announced that they were going to reassess all the data and exclude patients who were randomized 3 hours or later after injury. So if you look down at the bottom, about 9,000 total patients met these criteria. They recruited more patients. Initially, they were going to recruit a total of 10,000. They increased their sample size to approximately 13,000 to correct for this exclusion of these patients. So, long story short, overall, there was not a statistically significant difference found in these patients. So Essentially, the risk ratio was 0.94 with a confidence interval that crosses 1 for all these patients who were randomized within 3 hours of treat or of injury. Excluding patients with a GCS score of 3 or bilateral unreacted pupils, this was done. They actually announced their intention to also exclude these patients in one calculation at the beginning of the trial because these patients, when they arrive, are unlikely to benefit from any type of treatment. If you have no neurologic response and unreacted pupils, it's a sign of almost certain brain death. So these patients don't tend to benefit from anything that we do. So they excluded these patients to try to see in the patients that we would otherwise treat, is there still a benefit? So overall, and when they excluded those patients, still not a statistically significant difference. The difference comes when you look at the subgroup analysis. So they separated these patients into mild to moderate and then severe. So a Glasgow Coma scale of 9 to 15 was considered mild to moderate, and anything below was considered severe. So when you look at these patients with mild to moderate neurologic deficit on presentation, they tended to do a little bit better than the group as a whole. So they did find a statistically significant benefit to the tranexamic acid treatment in these patients. Anyone stop me at any time if you got any comments or thoughts to share. So this is another table that probably can't be read anywhere. This is a table outlining disability scores in surviving patients. So essentially, this is looking for harms caused by the treatment. Basically, what all these numbers show, they looked at a ton of different markers of disability, so push-pull tests, activities of daily living, that type of thing. There was no statistically significant difference in any of these categories in the treatment group versus the placebo group. So they did this in an attempt to conclude that the TXA treatment is likely safe and is not introducing any extra harms to these patients. When you stratify some of these results or separate them by time, that's when the differences become even more apparent. So the earlier patients get the tranexamic acid treatment, the better they do. Mortality is more significantly reduced the earlier patients get this treatment. So this kind of helps us when we're deciding, will we incorporate this treatment maybe into pre-hospital algorithms, that kind of thing. As time approaches 3 hours and beyond, you can see that the effective treatment becomes less and less. The severe, when you separate the severe patients, they tended to do about the same regardless of when you gave the treatment. It kind of makes sense. Like severe, when a patient presents with severe neurologic deficit, it means their hematomas usually have expanded to the point where they're causing this damage. The idea of treating these mild and moderate patients is to stop the bleeding from expanding. Once it gets there, there's not a lot we can do about it. But the real benefit of this treatment might be preventing neurologic damage from progressing. So limitations of this study, they're kind of what you would expect. So the primary endpoint wasn't all-cause mortality. It was 28-day head injury mortality. Mortality is so high in this group anyway. It would be really hard, I think, to power a study to really look at all-cause mortality. I don't know how many patients you need to enroll, but more than they could possibly do. One of the sources of maybe inaccuracy or bias is the attending clinician at the local site was responsible for determining whether the patient's death was due to head injury or not. So you're relying a lot on those clinicians, and it's a very varied group across the world. So depending on training in different countries or depending on experience with head trauma, this could have confounded the results a little. So as far as applying them to our local population, so there are only 7 North American patients enrolled in this study. All of them were here at the St. John Regional Hospital. A large percentage of patients were recruited in resource-limited healthcare settings, so Sub-Saharan Africa, Pakistan was a huge recruiter. India, countries that aren't considered to have the same resources as North American settings. So that could potentially play a greater role or a lesser role if these patients don't have access to the same level of neurosurgical treatment, ICU care, that type of thing. It was a really large sample size. They pretty much needed the number of patients they needed to get their to be powered to accurately assess whether or not this treatment made a difference. The big thing about this one, it's not a drug company sponsored trial, so there was no pharmaceutical industry funding for this study. It was sponsored by the London School of Hygiene and Tropical Medicine. But a lot of funding from UK governments, from clinical trial organizations. The funding to put this study off in Canada was received from the New Brunswick Trauma Program, which is a non-industry sponsored governmental organization. So, summary of the results. What it boils down to is that it may not be a benefit in severe head injury patients. Doesn't appear to really change outcome if your Glasgow Coma scale is 8 or less. But patients with mild or moderate head injuries are likely to benefit. As you can see by the disability analysis, or as you couldn't see, I guess, the TXA treatment is associated with very few risks, and those who are familiar with the drug know that it's associated with very few side effects and low cost. It's available generically, at least in Canada, and it's less than $10 per patient for the treatment. Early treatment seems to be the key, so the sooner you give this drug after injury, the better your benefit is going to be. So given the severity of head injury, it's not always clear when patients come in. So trauma patients are often, they often have comorbidities. We see often trauma patients who are intoxicated with alcohol or drugs. So it's really hard to discern whether the neurologic deficit is because of the injury or because of some other external factor. So for that reason, potentially we should be erring on the side of giving treatment even to those patients who initially look like they meet the criteria of severe traumatic brain injury, but we had no idea really of how severe it actually is, especially if there are any sedatives or anything else that might alter mental status at play. So how does it apply to us? I wasn't able to get the New Brunswick statistics, but head trauma and resulting intracranial hemorrhage are definitely a significant problem, just anecdotally, and I'm sure those of you who work in centers in other settings that care for these patients will agree. The patient population in the trial might be a bit younger than those patients that we see in New Brunswick. I don't know that for sure, but anecdotally, it feels like we see a few older patients with traumatic brain injury. A lot of these patients recruited in resource-limited settings, so we don't know exactly if the numbers, the risk reductions in that apply the same to our patients who might have access to more resource-rich care. And so tranexamic acid, in my opinion at least, you guys can all share yours as well, can be used to reduce mortality in this population. Mild and moderate head injuries are likely to benefit more than the severe head injuries. So, a few take-home messages, and then we'll go back and talk about our patient case. So TXA is safe when used for head trauma. The sooner you administer this drug, the more likely you are to get benefit from it. Reduces mortality in cases of mild to moderate head trauma. So a relative risk reduction in this subpopulation of, a relative risk of 0.78. And they do have a confidence interval there that does not cross 1. It approaches being smaller in significance, but it's not insignificant statistically. So tranexamic acid may or may not reduce mortality in severe head trauma. Those numbers probably suggest that it doesn't. So in my opinion, overall, the risk-benefit analysis favors administration routinely of tranexamic acid because of the extremely good safety profile and the possible benefit. What does everyone else think? So we'll go back to our case. I'll do a quick poll of the room. I'll let you refamiliarize yourself with the patient. Who says yes, give it. Who says no? For those of you who can't see us, everyone here says yes. So yeah, I agree. We really don't know anything about this patient when she arrives. The Glasgow Coma Scale of 9 puts her on the outside of kind of moderate head injury, approaching a severe head injury. We don't know why she fell from the ladder. We don't know what happened to her beforehand. But the fact that she does have a Glasgow Coma Scale of less than 12, you could even administer this treatment based on the trial before she had the CT scan. The tonic-clonic seizure, they didn't touch on this or separate these people in the trial, but that's certainly a symptom that would suggest an intracranial hemorrhage is present when she did in fact go for the CT scan. That's all, folks. Anyone have any discussion points?
What was the level? You don't know the level of severe head injury in our province. Like we were going to give it whether they had the lower score or not, right?
Well, that's up to your clinical interpretation of the evidence. I would suggest yes.
Yeah.
Because
I'm just wondering where so many came from those other countries where they may not be as, like you said, they may not have the resources that we have.
Right.
If statistically, I get probably why they got more from there because people drive on 3-on motorbike with no helmets. There's a larger population, more dense, blah, 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 so they're going to get the numbers. But if they don't have the same triage and the specialties service that we have here, I wonder if our head traumas, but we can't do it with the number that we had, 7, to see if they had that type of care, people with the lower scores may have done better than those with it.
It's definitely possible, and like the things that kind of benefit our setting versus some of these other places are we can get people to hospitals quickly. Now that's not necessarily an issue in more urban settings, but we have a decent EMS system. We can get people to hospitals more quickly. We can get this treatment to people if we allow EMS to administer this to patients. The Glasgow Coma Scale is an easy system for any healthcare professional really to administer quickly. Our EMS personnel routinely do this test on patients or quickly summarize this scale. So they're well positioned to choose whether or not to administer this treatment based on those numbers. So a robust EMS system and quick transport times certainly probably would favor.
I wonder if that number would come down a bit if it hurts.
It's hard to say because they don't give you a lot of detail in the trial about what the resources available were, like how quickly can patients access neurosurgery, how they can recover in ICU settings and that kind of thing, because those things are all likely to be associated with survival of head
28
trauma
days. First 2 days
as well.
Sure.
Yeah. Don't all speak up at once.
Do you think, so it didn't say that it improved disability, but like, do you think, just pathophysiologically, like, do you think it could, in theory, reduce the size of?
Yeah, absolutely. More severe head injuries are associated with more disability. So in theory, this is associated with, like, just judging by the mechanism of action, associated with decreasing size of intracranial hemorrhage. That's the theory. It's not borne out by the evidence necessarily. The surviving patients do about the same. More of them survive when they're given TXA. So I don't know how you'd assess exactly for disability. You'd probably need to assess only the survivors and whether or not, and you'd probably need more of them, because I don't know the exact mortality in this group overall. Let's see here. Yeah, so 20%-ish of these people died in both groups, like give or take a couple of percent. So you'd probably need more survivors to power for disability, I would think, just off the top of my head.
Well, and the other thing to consider is where the hemorrhage occurred, or where it's going to occur, because depending on part of the brain, you could have more deficits than others. It's not just the head itself, it's where it occurred, how big. Bigger bleed is always going to be worse, but you're going to have people with more deficits or less deficits, depending upon what the trauma occurred.
I guess if more patients are surviving, and actually, like on average, people are going to come out more disabled because some of the people that would have died had a worse hemorrhage. So when they do survive, they're going to probably have worse disability.
Potentially, but so that the benefit on disability of tranexamic acid might be offset by that point, because the big table that no one can read showed basically that the patients did the same in both groups. So perhaps, like you said, the fact that more people are surviving with more severe deficit is being offset by other patients, especially maybe in the mild to moderate categories, having less severe deficit. So for it to come out as a wash, like disability the same but more people surviving, you might be able to talk your way around that it is having some effect on disability. It's just being masked by those more severe patients who are maybe surviving.
Liam.
Yeah.
Hi, it's Glenn in Fredericton.
Hello.
Hi. I'm just wondering, so has Trauma NB updated their algorithms and modified the advice that they're giving to remote sites when these traumas come in, when that contact is made?
As far as I know, not yet. The guidelines haven't been, as far as their published guidelines, as far as I know, they haven't been amended to include TXA administration.
Okay.
I don't know the status of that. I know they do, suggest it for massive hemorrhage extracranially, and
Sure.
New Brunswick also, the advanced care paramedics in urban settings can administer the TXA in extracranial hemorrhage. I don't know the status of whether that's been changed for this as well.
Okay, thanks.
If anyone does, speak up.
But in all likelihood, too, now you're going to give it to anyone with trauma, right? So you're going to have people with other traumas.
That's where I think it's heading.
Yeah.
These guidelines are essentially clinician consensus documents. So, you know,
You're not going to exclude somebody from getting it now because they had a head injury, whereas before you did.
yes.
Right.
So we didn't typically in practice we wouldn't exclude patients before with head injury. We just wouldn't use it if they had an isolated head injury, because we didn't. Some clinicians certainly were taking the results from CRASH-2, extrapolating them to head injuries without actually knowing the answer. But in practice, anyone with a major extracranial bleed got it. And we still considered the extracranial bleed to have a benefit. If they had an intracranial bleed as well, so be it. Maybe it helped, maybe it did. But it wasn't an exclusion. It was an exclusion from the trial.
Yeah, but not in practice.
But not in practice. But yeah, to implement this into provincial guidelines requires people from all corners of the province to meet, discuss, stakeholder feedback. So the results of this were published in November 2019. So fiscal 2021, maybe it'll happen.
Have you guys been doing it as an emergency like this?
I haven't actually seen any isolated head traumas since this trial came out. The last person I saw was actually recruited into the trial. But anecdotally, even when we were actively recruiting, when patients wouldn't meet the official criteria, oftentimes clinicians were deciding to give this treatment anyway, outside of the trial, without knowing whether it would be effective or not, but just because of the safety profile. Like, if you bleed from anywhere in the emergency department, chances are you're getting a dose of it.
Sure.
Oh yeah. Can I tell there's like ding or anything?
Looks like nobody's typed any questions. You're good.
I'm not
Okay.
catching.
I'll let you.
Thank you very much, Liam.
Oh, thanks for having me.
Very well done. Very interesting.
Thanks, Liam.
Thanks everyone for coming to Journal Club. We'll see you in a couple weeks for Grand Rands. We have Janice Higginbotham from Moncton who is going to give us some tips on how to do presentations. So I encourage everyone to come out for that. And then at the end of April for Grand Rands, we have Dr. Steve Robinson talking about Suboxone and addictions. So thanks everybody, and we'll see you in a couple of weeks.